And with that, we will jump right into our case competition finals. The first so same rules as yesterday, 5 minutes of presentation, 5 minutes of discussion. So our first case will be presented by Dr. Youssef.
Good afternoon. I'm glad I made it to the finals. I'm Mina Youssef from Cairo University. I have nothing to disclose. I'll try to summarize the 7-hour story in 5 minutes. So, I have a 67-year-old male patient. He's hypertensive. He's not known to be diabetic. He's a chronic heavy smoker. He presented with typical chest pain of 6 hours duration. His ECG showed non-specific changes. His echo showed an impaired ejection fraction of 35%. His labs showed a rising troponin titr, so a diagnosis of non-STEMI was made. The plan was early invasive strategy the next morning. So his diagnostic coronary angio showed what looks like a simple mid-significant LAD involving the ostium of the first diagonal branch with Medina 111. He had a normal right coronary artery. So starting with a PT2MS wire was passed into the LAD. While passing the wire to the diagonal, there was no reflow in the LAD. So I pre-dilated the LAD. We got flow back. And then another wire in the diagonal branch. Then I pre-dilated the diagonal branch. After this, the strategy was to go for an early, provisional stenting of the LAD and act with the diagonal accordingly. After stenting of the LAD, 2 things happened. The first thing, the diagonal branch was lost. The second thing is that we had what looks like an edge dissection at the distal edge of the stent. So the plan was to try to recross, to re-enter the diagonal branch and then deal with the edge dissection. While trying to do this, a big thrombus formed in the left main to LAD. The patient was crashing actually at this time and was in agonizing chest pain. Unfortunately, in the cath lab this day, I did not have aspiration thrombectomy. So my plan B was to go for stenting from left main to LAD with an overlapping stent. I used a 4.0 by 48 drug-eluting stent, and here comes the next unfortunate event. The balloon failed to deflate in the ostium of the left main. The patient was crashing, severe chest pain. I tried the back of the wire, nothing worked. So I know you have to resist your instincts to pull, but actually I pulled and the balloon shaft was torn, but it deflated. And now I am left with a torn balloon inside the left main. I passed another wire and smaller balloon distal to the torn balloon. I inflated it at smaller pressures and tried to pull the torn balloon out into the aorta to try to snare it with the snare. I succeeded in this. As we see in the image on the right, the balloon was a bit out of the aorta, and successfully, using one snare, I pulled the balloon out of the left main. This was the balloon. I thought at this time that the job will be easy and I'll pass the wire and fix what I did. However, the crumbled metal was my enemy. It was not an easy job to enter the left main again. I passed a cyan black wire, and with repeated inflations with the smaller balloons starting by 1.5, going to 2 and 2.5, I got a flow back into the system. After this, I can see the middle part of the LAD, the one with the edge dissection. I fixed it with a stent, 2.75 by 28. But proximal and inside the stent, there was what looks like a hematoma or prolapsed tissue. I flared the left main stent. And this was the final images I got that day. By this time, we have spent 7 hours in the cath lab. I have used 400 cc's of dye. I got TEMI3 flow in the LAD. I lost the diagonal, and the circumflex was a bit compromised, but the patient was in no chest pain, and he was not in shock by this time. So the plan was to take the patient to the CCU, give him medications, follow up his creatinine after this huge amount of dye, and follow him up after 1 week with a control angio and do intravascular imaging. In my facility, the intravascular imaging is not available for ad hoc. Intravascular imaging, you have to arrange for it. So this was the plan. However, talking to the patient 2 days after the procedure, convincing him to go again for the cath lab, he told me, no matter what you say, I will not go to the cath lab again. Actually, I saw the patient 1 month ago renewing his medications. He was doing fine. I was curious to look into his coronaries again. I tried to convince him to coronaries. He told me, doctor, I will die when I'm meant to die, but I will not die in the cath lab. So my key learning points from this case, when dealing with bifurcation that will need a 2-stent strategy, please plan it ahead and don't go the easier way like of provisional stenting like I did. Always follow up the ACT. The problem in my case was the cannula was out of the vein. We give heparin and the patient felt no pain inside his arms. So I thought he was doing fine, but actually the ACT later on I discovered that the cannula was out and I need to give it in the sheath. And finally you have to have your cath lab fully equipped with all the things that needed for the complications, and especially the intravascular imaging is no more fancy today. Thank you.
Thank you. That was a really great case, challenging. Any comments from the panel?
So to Youssef, congratulations again. Very, very nice case, great save. I don't blame the patient not want to come back. So here are a couple of thoughts. So there's multiple issues, right? But where the major problem was, you put that stent and the balloon broke.
Yes.
I'm sorry, the balloon couldn't deflate.
Yes.
And of course, in the left main, that's life-threatening. And it's actually, what we're discussing, it's amazing. The patient didn't crash. I mean, usually they would go down and it's very hard. So that was great. One thing you can do after the balloon fractures, typically the fracture is at the monorail segment. So if you put another balloon next to it in the guide, inflate the balloon in the guide, pull everything out, often you're able to pull it back. Because if you pull really hard, the balloon may fracture. But again, that was very well done, and congrats for a great save.
Thank you.
Yeah, congratulations. That's amazing. You know, what a save. And, you know, it's kind of, we're spoiled here because we have all these tools. You know, I was like, where is the impeller? But, you know, so I understand you had limited equipment. You know, if you had to do it over again, I mean, you know, through the years of having complications, I think that the first thing to do, that you should consider when they have a complication or issue like this, take a deep breath. And I think that whenever I have overreacted, like, because the patient was hemodynamically stable, that's what I was just telling Manos. If the patient was crashing or something, then obviously you have to pull and do whatever. But, you know, would you have done anything differently now in retrospect, or you think you would have still just pulled? Would you have put a wire in the circ, put another balloon, like Dr. Bilateral said?
What I think I would have differently, since this case, I never put my heparin in the vein. I always take my heparin in the sheath. I always get ACT before I start. My previous practice was that I start the case, and after 30 minutes of heparin, I start my first ACT. But now I do ACT after the first dose of heparin. I don't know what else I could have done differently. Maybe I do not try a lot for the diagonal. Especially, it was a big diagonal, but the patient was actually in no pain when the diagonal was lost. Maybe I will not try for the diagonal later on, but I think it was a big branch. If it's repeated again, I will try for it, of course.
So these are, I call these rich emotional experiences, you know, these REEs, and I was having one just watching you. It's just crazy. So did you give thoughts as to, like, I'm trying to understand, do you have access to Impella or ECMO or... Okay, so how about CT surgery? I mean, were there any thoughts to calling?
I already contacted them. After the balloon was torn, while trying to snare it, it took me like an hour to snare the balloon. I led the resident that was assisting me to contact the CT, and they were on board ready to intervene at any time.
And how old was this patient again?
67.
Okay, so, you know, you know, if they're a little bit younger, you know, maybe they're able to tolerate these a little bit more because they have collaterals that appear magically from somewhere else. But, you know, in an older patient who, you know, is more vulnerable to ischemia, might be different. But I'm just so impressed. We're all talking about how stable this patient was with no coronary artery blood flow. It's pretty impressive.
The right was huge, Paul. I don't know,
maybe that's what
agree,
it was.
But the right
there
was
might have been
huge.
collaterals coming over.
So, you know, anyway.
Thank you.
Congratulations on the case. That's a great presentation. I applaud you for a heroic save. I'm glad that the patient is doing well. I think important for the trainees and early practice physicians in the room here, sometimes, I mean, complications happen, right? You do the number of cases that you do and complications happen. It's not having a complication that can lead to bad outcomes. It's actually subsequent decisions that one makes. So don't panic, call your partners, call everyone. As Mina Youssef likes to say, call everyone for help, right? So having that support, you know, having a second set of hands, second set of eyes, second set of mind to kind of bounce back ideas is important too.
Yes.
Thank you.
Thank you so much.
Next, I would like to invite up Dr. Gergis to discuss CTO PCI in woven anomaly.
Good afternoon, everyone. Thanks for having me in such elegant meeting. My case is CTO PCI in woven anomaly. I'm Michael Gergis from Aswan Heart Center, Egypt. I have no disclosures. Clinical data for the patient, he is 60 years old gentleman. He is hypertensive, ex-smoker. He underwent PCI to the LCX back in 2010, and he remained asymptomatic till 3 months before this presentation with worsening angina. He underwent coronary angio at another facility that showed total occlusion of the LAD and the RCA with a woven anomaly in both arteries, with patent stent at the LCX. So he was referred to our center for heart team discussion. Actually, his echo showed akinesia at the LAD territory with thinned out segments. So let us see the angio. He had some slow flow with patent proximal LCX stent and total occlusion of the distal OM. And this is a shot at the conal branch of the RCA where it gives very formed collaterals to the LAD. And this is RCA angiogram. You can appreciate the long segment of occlusion with woven anomaly. Woven coronary anomaly is an epicardial vessel segment that divides into multiple intertwining segments with eventual convergence at the distal segment of the artery. It's a rare anomaly with incidence reported less than 1%. PCI is usually challenging in such context. However, when the LAD is out of the equation, PCI is easily justified over CABG in those patients. So my plan with the case was to start with an antegrade approach to the RCA, and plan B was to go retrograde through this conal branch. However, what is not an easy question to answer here is how this segment behaves through an epicardial segment down to the woven anomaly, then through the septal. So I was hoping to finish it antegradely. My setup to the case was two amplets guiding catheters, one in the RCA and one at the left system, to easily shift the second amplet to the conal branch if I went retrograde. The setup was Corsair Pro microcatheter with a Gaia second. At the start, the course of the Gaia I was not totally comfortable with the course. However, when looking at different projections, it looked within the vessel architecture, and in this view, it's towards the distal RCA. And here at replete with a workhorse wire, and after dilatation, TEMI3 flow was established. I put an IVAS catheter to look at the segment, and you can see here a lovely demonstration of the multiple branches within the woven segment. Branch appears here, or lumen appears here at 12 o'clock, another one at 11. Then they unite together into bigger branches. Then this is the proximal RCA. This is a nice first reported histopathology of the woven anomaly of a patient. He underwent CABG, and 1 centimeter segment of the woven anomaly was excised, and histopathology examination was performed. This is in 2013, lovely demonstrating the endothelial lining of the different lumens, and they are outermost coat is formed of 1 layer of uninterrupted internal elastic lamina. I have put a stent 3.5 by 48 proximally, after which I had a impaired flow distally. I deployed, giving some intracoronary drugs, then deployed another stent. Another 3.5 by 48. And the IVUS showed some disease at the distal RCA. I didn't want to stent all the way to the distal segment, so I finished with a DCP, paclitaxel DCP at the distal RCA with this final image. So my take-home message in this case that woven coronary disease is rare pathology with unknown etiology. This was initially thought to be benign. However, recently reported, a lot of case reports report significant ischemia at the woven anomaly artery. And final PCI is doable in such patients, and intravascular imaging is helpful both in planning the landing zone and vessel sizing in this scenario. Thank you very much.
Great. Comments from the panel?
Yeah, great case again, very nice presentation. Obviously something we don't see very commonly. I guess another consideration here, I mean, you do have LAD, you have other vessels, so bypass would have been also a reasonable option in this patient, but great result, and again, great intravascular imaging pictures here.
Thank you.
There we go. Yeah, congratulations. Just one question. It looks like the collateral to the LAD might have been covered in some of that stenting. Was that a concern at all?
Actually, the LAD was collateralized from both branches, some RV branches and the single dominant conal branch. This conal branch was not filling if the catheter is down the way to the proximal RCA. Okay. But I took a non-selective injection, so the conal branch was still there. However, the LAD territory is not viable, but I assure you, it was not lost.
Yeah, well, it was a great presentation, and congratulations.
Thank you.
Yeah, I have really no comment. Great job.
Thank you.
Congratulations, that was a great case, beautiful pictures. I'm a vascular surgeon. I think these coronary angiograms are phenomenal. So if you can make me see a lesion on the coronary angiogram, that's great. That means it's a fantastic picture. And so, so congratulations.
Thank you.
And we'll move on to our next case, also a coronary case, presented by Dr. Ravishankar.
Good afternoon. Thank you for having me. My name is Milan. I'm one of the general cardiology fellows at Baylor University Medical Center. I'd like to also thank Dr. Chugh for his mentorship in presenting his case. So our scenario starts with a 25-year-old gentleman who has no prior cardiac history, no prior cardiac symptoms. He's a daily electronic cigarette user, and he has no family history of premature coronary artery disease. And he started to experience chest pain while at rest, and after it didn't go away, he presented to the ER, where a 12-lead EKG confirmed a STEMI in the inferior leads. So he's taken for an emergent coronary angiography. A right radial artery approach was taken. The right coronary artery was visualized first and was confirmed to be angiographically normal. At this point, a 3.5 EBU was used to engage with the left system and confirmed a 100% left circumflex occlusion. The initial angioplasty was done successfully, and Asahi softwire was used to easily cross the lesion, and a 3.0 by 15 semi-compliant balloon was used for inflation. At this point, the patient's chest pain resolved, and the ST segment elevations normalized on his EKG. In anticipation of stent delivery, a buddy wire was placed in the adjacent ramus artery, and a 3.5 by 20 onyx frontier was delivered to the lesion site in the left circumflex. At this point, the stent balloon was inflated to 14 atmospheres. Of note, the rated burst pressure for this stent balloon is 16 atmospheres, and the operators noticed that there was difficulty in further inflating the balloon. Additional angiographic pictures were taken, and it confirmed that the stent itself was only partially expanding proximally and was not expanding at all distally. We can also see that as we further inflated the balloon, we can see contrasts going into the distal vessel, which confirms our concern that a stent balloon rupture has happened. So at this point, the nature of the case has changed. It's no longer a simple primary PCI. And so we have to come up with a timely solution to treat this problem, but also with the understanding that this patient's chest pain has resumed and he is again having ST segment elevations. So the first idea was to just attempt to pull back the ruptured stent balloon. Unfortunately, by doing this, we see that the stent balloon is still connected to the partially deployed stent itself, and the stent moves proximally to the ostium of the left circumflex. So the next approach was to place a blocking balloon over the ostium of the left circumflex. Fortunately, the anatomy was favorable to this. And so using the buddy wire that was in the ramus, we're covering the ostium of the left circumflex, and you can see the markers of the stent balloon moving back into the guide as we pull back on it. IVUS was done afterwards, in part to confirm that the stent was well opposed, but it also shows us that this vessel was not heavily calcified to begin with. And it also confirmed to us that the partially deployed stent, even though it was moved proximally with our first attempt, was still long enough to cover the entire lesion site. And so additional stenting was not needed. And this is the final angiographic images confirming TIMI-3 flow and a well-opposed stent. The final image is of the ruptured stent balloon itself, and you can see the jet stream of water coming out at 12 o'clock on the screen, and it's just confirming that there was a pinhole rupture in this stent balloon. And so my learning points after this case were that stent balloon rupture is an infrequent complication of angioplasty, but it can occur typically due to heavily calcified lesions or if high pressure inflation happens, but a manufacturing defect is also a possibility. Contrast streaming from a ruptured balloon can potentially cause dissection or perforation as well as air embolization. And the blocking balloon technique can be used to prevent proximal stent migration if such equipment needs to be removed.
Congratulations, that was a great case. As a non-coronary interventionist, I do have a question. Having dragged my fair share of devices across arteries, do you worry about the part of the artery through which the stent had been dragged through when you pulled it back? Do you have to image that extra or stent across that?
We didn't see any evidence of endothelial damage on the IVUS, and with the return of the TIMI-3 flow, I think, and with the final angiography also confirming there was no perforation, along with the resolution of symptoms at the end of the case, we felt confident that he was going to do well.
Any questions from the panel?
So great case, and this is a classic example that there is no such thing as simple PCI, because what seems simple can very quickly turn into something different. So 3 points. First of all, regarding what happened. So you didn't have calcium, you didn't have difficulty delivering, you didn't go high pressure. So this might have been a manufacturing defect, which is not very common, but can happen. Second, when that happens, the very creative solution was to block the stent. Now, you could have pulled the stent back and try to get into the guide. The problem is it was expanded proximally, so chances are you wouldn't have been able to do that, and you may have had to deploy it in the left main and then do pot, which still would be not a bad option. The third point is what you mentioned. When this happens, when you have a balloon rupture, you should always do a picture, because sometimes you do have a perforation or a dissection, but perforation is the main concern. And if you don't realize it immediately, by the time you do, when the patient gets tamponade, that may be a little too late. But great save.
Thank you.
Yeah, a very interesting case and great presentation. Both cases, the first case and this case, did you try to advance the balloon first? Because sometimes I think that we always think that we should pull because we're trying to remove them. Sometimes if you try to advance, that will release the balloon and then you're able to pull out. Did you guys try that? Were you at in the case?
That was attempted, and that's why we were fairly confident that the distal portion of the balloon was still well attached to the distal portion of the stent.
I guess the other side question I have is that did you image the lesion before stenting it? Because the unusual case, 25-year-old, no family history, no risk factors per se aside from vaping. Did you think it was appropriate to image it before putting a stent just to get a better understanding?
There was also IVUS imaging done before the initial, before the stent was placed, and that was used to determine the lesion size and how large of a stent would be needed. But no calcification was seen there either.
Wonderful. Thank you.
Great.
Thank you.
Thank you. Next, it's my pleasure to invite up Dr. Pham to discuss the distorted osteocoronary stent masquerading as a type A aortic dissection.
Good afternoon, everyone. My name is Thuy Pham. I'm an endovascular fellow at Baylor Scott White in Heart Hospital Plano, and where I did my interventional training as well. Happy to share with you our case today, a distorted right coronary stent masquerading as a type A aortic dissection. I have no disclosures to share. Our patient is a 74-year-old female with multivessel coronary artery disease at an outside hospital. She had a CABG evaluation, but was deemed a poor surgical candidate and poor distal targets, so she was referred to us for an elective multivessel PCI. We decided to start with her RCA PCI and then stage her left main OM later due to her CKD stage 3. We did our RCA PCI with 2 overlapping 3.5x38 drug-eluting stents, post-dilated up to 24 ATs with a 3.5 non-compliant balloon. She was discharged later that day, but an echo post-procedure was concerning for an aortic dissection, so she was asked to return to the ED for an emergent TEE. Her TTE and TEE images demonstrated a linear echo density protruding from the right coronary cusp into the ascending aorta, concerning for a type A aortic dissection. CT surgery was consulted, and we got a CTHS for further evaluation. Her CTHS report did not mention a dissection, nor did it mention what we see here in these images, which is what we think is a segment of the RCA stent protruding out from the ostium into the ascending aorta. To confirm this, we brought the patient back to the lab and did cine images, which confirmed our suspicion. So here's our clinical challenge. We have a recent RCA PCI, echo images that suggest a type A aortic dissection, CTA images and cine images that suggest otherwise, but rather it's a distorted, stretched out stent segment protruding out from the RCA ostium into the ascending aorta. Well, what do you do next? As interventional cardiologists, we brought her back to the lab for a percutaneous procedure to separate and explant the distorted stent segment. We started with an 8 French sheath and a multipurpose 1 guide from the right common femoral artery, and a 6 French sheath and a JR4 guide from the right radial. We advanced a BMW wire to the distal RCA. We took a 25 millimeter gooseneck and through the MP1 guide to secure the protruding segment, and then sheathed the MP1 guide over the stent segment down to the RCA ostium. We inflated a 3x15 compliant balloon to anchor at the ostium to try to snare it out, and then we tried to cut the stent segment with a 3.75/10 Wolverine, and neither of those worked. So we took a 1.5 rotational burr to cut the distorted stent segment at the ostium, initially in a coaxial direction, which it did not work, so we removed the guide catheter just a little bit for a superior direction, which then cut the distorted stent segment, allowing it to be pulled into the MP1 sheath. We carefully removed the MP1 guide from the body, revealing the distended stent segment on the snare, as you can see here. We finished with a 3.5 by 18 drug-eluting stent at the ostium and post-dilated with a 4 by 15 non-compliant. Here's our final angiogram and IVUS images with acceptable results. So to conclude, the resolution of our challenge was a percutaneous explantation of the distorted stent segment from the ostial RCA that involved dual access with a JR4 guide from the right radial and MP1 guide from the right common femoral, a gooseneck snare inside the multipurpose guide to sheath over the distorted stent segment, and then, safely as possible, a 1.5 rotational burr at the ostial RCA to cut the distorted stent segment, securing it inside the MP1 guide with the snare. 4 key learning points from this case, the first 2 which are related. Perform a final angiogram without the wire and disengage the guide catheter under fluoroscopy. Our working theory is, at the initial PCI, when the wire was withdrawn and the guide was disengaged, it pulled on a proximal strut stent, stretched it out of the ostium into the ascending aorta, which gave that appearance. Neither of these steps were captured under fluoroscine, unfortunately. Next, review and use all available imaging. We had fantastic echo images that suggested an aortic dissection, which would have meant a very different management for the patient. We also had excellent CT images that demonstrated it was not a dissection. Something as simple as cine images allowed us to confirm this diagnosis. And lastly, our case demonstrated the off-label use of a rotational atherectomy burr to cut and separate a distorted stent segment at the ostium RCA for safe explantation from the body. Thank you to our team and your time for this case.
That's an impressive save. I don't think I would be able to do that, actually. I'll turn to the panelists to see if there's any other things that you could have come up with to remove this distorted segment.
Well, first of all, congratulations again. Phenomenal case, very creative solution. So couple thoughts, couple questions. First, so it was a fresh stent, right? It was just recently placed. Why not leave it in place? So why just leave it there? Was it causing ischemia? Was the patient having any symptoms? Or it was just the imaging finding?
Yes, sir. So that is the million-dollar question. And when I moved to Texas, I learned what the definition of a cowboy was. I'm just kidding. I actually don't think this was a very cavalier move at all. Thank you, Dr. Saraja. I think that there was very careful and intentional thought into this case. We had an extensive multidisciplinary discussion, and we felt it needed to come out for several reasons. Number one, you have a distended segment at the ostium of an RCA that you freshly put in 2 overlapping 3.5 by 38 stents. So your risk of acute thrombosis or stent instant restenosis in a vessel that you just have long stents in is likely increased because we don't know the integrity of the ostium of the RCA at this point. Secondly, we don't know if this stent segment is going to spontaneous dislodge, embolize, or come off. There's just no way to predict that. So once the decision was made that it needed to come out, our next question then, was it surgically or was it percutaneously? She was already a non-surgical candidate for coronary bypass, and so we felt the best approach for her was a percutaneous option.
Perfect. And then the second point is, so it was a fresh stent. Why not just snare it, pull it out? I mean, the rotablation is very cool, but this is a fresh stent, so if you pull hard, it's going to come out, and you can just put another stent. So why do the extra step of rotablation and cut it versus just pulling it out?
Yes, great question. I didn't stay on that slide very long. We did initially try to just snare it out with extracting it, pulling it, and it did not separate. And what we saw is the snare was just elongating inside the multipurpose snare. So we felt like it was just elongating the stent segment, and it wasn't actually separating the stent with just pulling it.
Good. It's a great case. First of all, cowboys get a really bad rap. They're actually very friendly folk. So I know lots and grew up with them. So, but congratulations, that's a great save. So I actually had a very similar case with a wire fracture where we snared it in the aorta and then used a rotablator to cut it. And it actually works pretty well, but the key to doing that is to make it super taut. Because if you don't pull what you're trying to cut super taut, you run the risk of wrapping the rotowire, the rotoburr around it, and then you make a situation 1,000 times worse. So the key is when you have it on the snare, pull it super hard, and then you can pass the burr next to it, and it actually cuts pretty easily. So it's a great case.
Thank you.
Yeah, it's definitely a great case and great presentation. I guess my only interpretation is that, we always say, in the lab, we get lucky, to be honest with you. I mean, yes, there is some technical dexterity that you have, to get you through these cases, but a lot of times we get lucky. I guess, what were your plans in regards to, like, what were your thoughts about things that could go wrong? And how did you guys plan for that? Like, what if you pulled on it and it broke into 2 pieces and a piece went into the carotid? Or, while you were putting the rhodo touched the aorta and dissected the aorta. What were you planning in regards to, the different things that could go wrong in a situation like this?
Absolutely. So to answer your first question, to prevent any segments or parts of it dislodging or embolizing, we've made sure that the distorted segment was sheathed inside the multipurpose guide. So it was almost like a sheath or a hub for it. And like Dr. Siraj was saying, as we were rotablating, we did have tension on that snare multipurpose guide to minimize different parts of that stent segment being rota, and trying as best as possible to just rota one focal point of that segment.
Congratulations, that was really an excellent presentation. Next, our next presentation will be Dr. Feroze.
Thank you all for having me. My name is Rafey Feroze. I'm a third-year general cardiology fellow at University Hospitals in Cleveland. And the title of my presentation is Massive Pulmonary Embolism. I have no disclosures. So today we're talking about a 28-year-old female with a past medical history of recurrent tonsillitis. And one of these episodes, 5 months before our case, caused her to have a provoked right IgA thrombus, and she was placed on Xarelto for 3 months. She also had a history of 2 miscarriages, and then she presented again with a peritonsillar abscess, but this time with significant respiratory distress and syncope. So in the ED, she was intubated for hypoxia, and then in the MICU, developed hypotension, tachycardia, and increasing ventilator requirements. Significant family history of DVTs in her maternal grandmother, and she was an active smoker as well. And as I said, no longer on anticoagulation when she came to us this time. So because there was some uncertainty as the cause of her shock, and due to her recent thrombotic event, a CTPE was done, and I'm trying to play some of the videos here. As you can see, there is significant clot burden in the right and left main PA, particularly on the coronal image, and there was also reflux of contrast in the IVC. So we now had a diagnosis. There was significant RV strain with an RV to LV ratio of 2.3, and her parenchymal lung imaging showed some left basilar ground glass opacities, suggesting pulmonary infarction. A surface echo was done, which showed a severely dilated RV with severely reduced RV function and RV pressure and volume overload. And she also had developed new moderate to severe TR with an RVSP of 61. At this point in the ICU, she had a blood pressure of 66/42, not on pressors. She was tachycardic to 114, subsequently started on pressors. Her labs were significant for an acidosis with a pH of 7.19 and a lactate of 2.1. She had a new AKI at 2.02, leukocytosis of 21.2, and then her cardiac biomarkers were elevated. Her PESI and BOA scores were significantly elevated as well, suggesting a high-risk PE, and because she was on about 0.2 of norepi at this time, this was considered a massive PE. So this led to a PERT team discussion at our institution about what the next option, best option is. So the big choices were to continue anticoagulation, to attempt systemic thrombolysis, or some kind of catheter-directed treatment. Because she was somewhat stable on a moderate to high pressor dose, we chose not to proceed with systemic thrombolysis, and a catheter-directed option was selected. But there was concern that she had obstructive shock, she was on pressors, and how best to support her through this. So that leads us to our clinical challenge of how to perform thrombectomy of a massive PE in the presence of obstructive shock. So the PERT team discussion led to the consensus of doing a endovascular procedure with ECMO support. So the left femoral artery and vein were cannulated for via ECMO, and then the right femoral vein was cannulated via micropuncture, and a 24-French sheath was placed, and we did a pulmonary angiogram, which shows significantly reduced flow in the left and right pulmonary arteries. After this, a soft wire was advanced into on the right side, and then a GR4 catheter was advanced over it. The wire was exchanged for a stiff amplas to provide more support, and a pulmonary thrombectomy catheter was then advanced into the right main PA, where we believe the clot was. And the goal here is to get the tip of the catheter right where the clot is to optimize aspiration. After aspiration on the right side, we then brought our attention to the left side, and here's the clot that was removed. Right after the thrombectomy, her RA pressure improved from 15 to 9, her PA pressures improved, and then her cardiac output and index were normal, but on VA ECMO. After that, she was taken back to the CT ICU this time. The day following the procedure, ECMO was decannulated. The day after that, she was extubated, and a repeat surface echo was done 4 days after the procedure, which showed a significantly less dilated RV, significantly improved RV, in fact, normal RV function, and some trace TR. And there was a small clot in the IVC, or what we thought was clot, likely from ECMO cannulation. She was transferred to the floor, and 2 days later discharged on apixaban. 6 months after that, the plan was made to continue anticoagulation due to the severity of this incident. And then 9 months later, she had a CTPE for unclear reasons, which demonstrated no clot burden. And 12 months later, she completed a pregnancy and gave birth to twins. So some key learning points from this case are that as endovascular options for PE become more common, the question comes up that when people are unstable, but not quite as unstable to require systemic thrombolysis, how can we support them? And VA ECMO should be considered in the discussion. And that's all I have. I would like to thank Dr. Lee.
Congratulations, that was a really great case and an excellent presentation. We see a lot more of these salvage cases for massive PE and the PERT team. Can you talk a little bit about the decision for VA ECMO here? It's a relatively new thing.
Yeah, so starting with all the options, just anticoagulation, it was felt that given her young age and the fact that she was on such high dose suppressors, that just anticoagulation would not be sufficient. And then at the same time, she was not quite so sick that we were worried that she was going to code any time to give systemic TPA. And when someone develops RV failure, they go into the spiral of worsening cardiogenic shock, and as a bridge to the thrombectomy, and then also to provide a safety net in case something goes wrong in the procedure, that was part of the reason for choosing VA ECMO.
Great. Any questions from the panel?
Rafey, great presentation. I guess, what are some of the special things you should consider if you're doing the embolectomy in a setting of an ECMO? Are you familiar? There are some concerns about, air entrapment and those kind of things. Are you familiar with that? Any comments about that?
A little bit. So when aspiration is being performed, I believe that the ECMO flows should be reduced to help not entrap air, and then those flows can be increased again after clot is removed. Actually, that's sort of the extent of my knowledge.
Yeah, that's an important point. I just want to make sure that you are aware of it. That it's when you're performing this kind of procedure, because we're doing suctioning, it's important to turn the ECMO down during the actual suctioning and the embolectomy. Manos and Paul.
Yeah, congratulations, excellent case, and we don't do these cases, but I guess the question is, how do you choose about thrombectomy modality? Now, there are many options out there. Are there any specific things that work better for this situation, especially having the ECMO in place with the risk of air embolism, or any device could potentially work?
Yeah, so at our institution, we mostly either use ECOS, which is catheter-directed thrombolysis, or Inari. Now, if someone has a contraindication to TPA, even localized TPA, then the decision is easy to choose thrombectomy. In this case, this patient did not have a contraindication to TPA, so the argument could be made that, why not use ECOS? Given the proximal nature of the clots, the thought was that thrombectomy would be able to provide significant debulking of the clot.
Okay, great. Thank you very much. Great case.
Great. Next, we'll invite back Dr. Pham for her second case presentation, which is stick, snare, shockwave, and stent, how we tackled severe bilateral iliac disease.
I will spare you guys the reintroduction this time, but I will thank you for letting me share a second case. As Dr. Lee said, stick, snare, shockwave, and stent, how we tackled severe bilateral iliac artery disease. I still have no disclosures, but maybe after today I can remove this GIF from my presentations. Our 83-year-old female was referred to us for carotid artery disease, abdominal aortic aneurysm, and bilateral iliac artery disease. She reported possible amaurosis fugax and about 6 months of bilateral hip claudication. She had chronic shortness of breath, but fortunately no chest pain, TIA, CVA, or non-healing wounds or ulcers. In 2018, she had a right carotid endarterectomy, but on most recent carotid ultrasound, she had moderate to severe left internal carotid artery stenosis. She had a 4.0 centimeter AAA back in 2017 that was relatively stable, but had enlarged most recently to 4.8 by 5.1. And she had moderate bilateral iliac artery disease back in 2019, but on most recent CTA abdomen and pelvis, she was found to have severe right common iliac artery disease, as well as an occluded left common iliac artery. To round that out, she was a former smoker, COPD, on home oxygen. So before we tackled her AAA and bilateral iliac artery disease, we wanted to rule out carotid disease, and luckily on her carotid angiogram, she had just mild disease bilaterally. Using our common femoral access for that procedure, we did perform a limited angiogram here, which confirmed that she had a significantly enlarged calcified AAA, a right common iliac artery, 80% stenosis with a 23 millimeter gradient, and what appeared to be an occluded left common iliac artery. So she needs an EVAR, but she has severe bilateral iliac disease. So what do you do next? We consulted our vascular surgery team, and she had no infrarenal neck for a traditional EVAR. She would likely require a 3-vessel physician-modified endovascular graft repair. So to avoid the challenge and the complications of a large bore device delivery usually required in a PMEG, we decided to start with her percutaneous intervention of her bilateral iliac arteries and then stage the PMEG. So we started with bilateral common femoral artery 6 French sheets. To get a better picture, we advanced a 5 French omni flush from the right common femoral artery, this distal aortogram, which confirmed our findings. We were unsuccessful to cross the left common iliac artery in retrograde fashion from the left common femoral artery using a Navicross, a Command 018, and an Astato 30, and we quickly realized that this was a CTO. So what do we do next? We went up top. We got right radial access for an antegrade crossing strategy of the left common iliac artery CTO. We started with a 6 French short sheath, used a 5 French vert, a glide wire, a Navicross, a Command 018, and an Astato 30. Still were not able to cross. So we switched out for a 6 French, 105 centimeter destination sheath, and using a 5 French vert, we were finally able to cross with an Astato 30, as you can see here. We then took a 10 millimeter gooseneck snare to externalize that antegrade wire through the left common femoral artery. But what this allowed us to do was also provide a rail so that we could advance our microcatheters across this left common iliac CTO. That allowed us to perform balloon angioplasty, first with a 3x40 Crostella and then a 5x20 Sterling balloon. We switched out our bilateral 6 French sheets for 8 French sheets to allow for the larger L6 shockwave balloon, starting with the right common iliac artery and then the left common iliac. And that allowed us to deploy 10x57 Visipro stents, first in the left and then the right, and then perform a final simultaneous kissing balloon angioplasty with our final angiogram here. So to summarize, our resolution of the challenge of having a severely calcified AAA requiring a PMEG in the setting of severe bilateral iliac artery disease was to stage her iliac artery intervention and then follow it with an eventual 3-vessel PMEG, which she's scheduled to have later this year. The key learning points here are the multifaceted approach of her PCI requiring angioplasty, shockwave L6, and stenting of her bilateral iliac arteries. It started with the stick, 3 access sites, bilateral common femoral artery, and more importantly in this case, the right radial artery, which facilitated our antegrade crossing strategy. That then allowed us to snare and externalize our antegrade wire and give us a rail to pull through our microcatheters through the CTO. Using our bilateral common femoral artery axes, we were able to upgrade our sheets so that we could use the larger L6 shockwave balloons to attack these heavily calcified iliac arteries. allowing optimal deployment of our balloon expandable stents and kissing balloon angioplasty. Thank you guys for your time, my attending Dr. Srini Patlori, and the team for this case.
Great case, Thuy. And as we discussed during the initial presentation yesterday, always important to have 3 access points to tackle tough CTOs, especially in the iliac artery, and planning ahead in the event of a perforation, having the appropriately sized sheaths, and having cover stents in the room, etc. Panel?
I have a question. So great case. I agree with doing the PMEG. The last thing you want to be doing at the same time is trying to recanalize the iliac. So a couple things. When you are recanalizing bilateral iliacs, did you think about raising the bifurcation? Because you're going to have to deploy a bifurcated graft into these, right? So sometimes if you raise the bifurcation so high, you are limiting yourself, because the bifurcated graft of the PMEG is going to be a fixed size. You modify the main body part, and then you have the 2 limbs. So sometimes you end up with a problem with the limbs. You have to get the limbs into your iliacs that you've put up there. So did you think about how high you're going to raise the bifurcation? That's one thing. The other way out of this is to recanalize one side, leave the other side occluded, and do like an aorta uni into the one side, and then you will need to have arm access to do the rest of the fenestrated. So were those sort of thought about? Really, it's raising the bifurcation mostly because I've had this problem where the bifurcation is way up there, and then you can't deploy your bifurcated graft into it.
Yep. So we did discuss this case with the vascular surgery team, reviewing the CT images, and we did not feel that raising the bifurcation was necessarily needed or need to be addressed in this case. And we did collectively decide as well, because of her COPD and not wanting a long procedure, staging both bilateral iliac arteries and then separating the PMEG at a later procedure.
Other thoughts from the panel?
I guess, how old was the patient? I'm sorry to...
83, sir.
83, right.
Yes, sir.
I guess, with the single limb, endograph and then a Pham, did you guys discuss that? And why wasn't that considered in 83-year-old COPD, multi-level disease, carotid disease, all kinds of stuff?
Yes, I think that was probably left up to patient preference, and she did not want to consider those options.
Okay, great. Most of my patients don't know what's a Pham, but that's great that your patient is so knowledgeable. That's wonderful.
Well, I mean, we obviously explained those options here, but yes.
All right, thanks.
Great case. Thank you very much. All right, we'll have our next case now presented by Dr. Asif.
Good afternoon. I'm Anum, one of cardiology fellow. And the question I'm bringing today, can you perform TAVR when there is no access? Or is this a mission impossible? Let's see if innovation can help us. I have no disclosures. We have a 76-year-old male with multiple comorbids, peripheral vascular disease, COPD, prior radiation, who has been suffering from heart failure with preserved ejection fraction and severe symptomatic aortic stenosis. He was turned down for both SAVR and TAVR because of his high surgical risk and lack of access. Fast forward after a year, he courses through the natural progression of his disease. Now the EF is down, he's symptomatic, he's unable to tolerate medications, and he's knocking at your door asking if there is any option. So you can see valve area less than 0.6, EF is down, classic low flow, low gradient ES. So what's the challenge here? It's just another TAVR. Basically, we have no access on this patient, and let me show you why. So here you can see distal abdominal aorta is occluded, his bilateral common iliacs heavily calcified, making transfemoral not a viable option. We also explored transcaval, but you can see significant disease in the descending aorta, making it hard, a challenging access. Bilateral common carotids have significant disease, small vessels. His subclavians were also 3-millimeter vessels, significant atherosclerotic disease, wasn't an option. And then, worst for the last, porcelain aorta. You can imagine a discussion with our surgeons seeing this on top of his elevated surgical risk. So any surgical access was off the table. So what do you do next? We had a multidisciplinary team meeting. We put every options, discussed risks, benefits, patient preferences, and came up with a plan. If we can successfully perform an aortoiliac reconstruction, maybe we can offer him transfemoral TAVR. So we proceeded with aortic reconstruction. Here you can see we have bilateral femoral access with French sheets. We tried to cross retrograde using a glide wire. We were not successful. This was followed by an Asahi wire using a microcatheter. And you can see here that we are in the subintimal space. We know from all the talks, yes, stay in the true lumen, but this classically it's not happening for us. So what we did next, before proceeding further, we got a third access via left brachial artery. Not to mention that this patient has bilateral significant disease of radials, and they were tiny. So you can see in the angiograms that we are clearly in the subintimal space, and the distal abdominal aorta is occluded. After confirming that, we exchanged our microcatheter with the Pioneer IVUS-guided reentry catheter. The experts may know, but for the fellows like me, it's a catheter which is used in peripheral CTO interventions, and the way you do it, you visualize the aorta at 12 o'clock position and fire your needle to gain access to the true lumen. And you can see we performed this step on the contralateral sides, and we were able to gain access to the true lumen. And this was confirmed with the IVUS. On your left-hand side is an IVUS imaging showing that we are in the true lumen. This is just a schematic representation for the fellows just to see how this catheter works. At the end, we performed bilateral kissing stents with Viaband 7mm stents. They were post-dilated with 9mm balloon. You can see the final angiogram. There is good flow through the aorta, and the stents are well expanded. At the end of the procedure, we perform a bridging balloon valvuloplasty because we don't want to create another challenge where your stents are flying off performing TAVR on the same day. So we performed a balloon angioplasty and waited for 3 months. At the 3 months after allowing for endothelialization of the stents, we performed a staged TAVR procedure. On the day of the procedure, you can see the angiogram with good flow through the aorta and also good expanded stents. We were able to advance our equipment by a standard transfemoral access without any issues. Patient underwent successful implantation of SAPIEN 3 26mm valve, as you can see here. On his 30-day visits, patient did well. His EF got better, and his gradient across the valve is essentially normal. He's been feeling great. He just had a year follow-up with us, and he's been clinically doing great since then. So take-home points from my talk. Aortoiliac reconstruction is a viable option in patients with severe peripheral vascular disease. And it is important to learn these skills for a successful TAVR program because we know we often take care of those patients who have exhausted multiple options and are knocking at your door to see if there is anything that can help them. Thank you so much for your attention.
Very good case. Excellent presentation. We see a lot of these TAVR patients who really have challenging access, and this was a great way around it. My question is, you had occluded iliacs and an infrarenal aortic occlusion and recanalized the infrarenal aorta. Did you check to make sure the tops of your stents are in good aorta? Because sometimes you can't really tell, right? You cross the occlusion and you don't know if maybe there's a flap or a plaque kind of obstructing the inflow to one of your stents?
Yes, we have confirmed later on with the IVUS too, and as before proceeding with anything like this, you know you're crossing from the subintimal space through the true lumen. Everything was confirmed with the IVUS before proceeding further to avoid any complications like this.
Other questions from the panel?
I love the multidisciplinary approach. That's fantastic. A couple of questions for you. And this is actually for anybody. 3 months to wait for these things to heal in before you let me put in a TAVR? I just want to make sure I understand that, because 3 months, these patients may not be alive.
So we looked into it. They say whenever you intervene, at least wait for 3 to 6 months just to endothelialize. The problem is we didn't want to risk doing the TAVR at the same time where you have fresh stents in, you are pushing your equipment through it, and they can get dislodged, you can have perforations, and then we are in big trouble then figuring out like how to fix those things. So we wanted to give him some time, and also he has heart failure. We wanted to optimize him further before we can advance and do a TAVR procedure on him.
Yeah, I think when we do this, when we have like large bore access, small, you see it a lot in the external iliacs. Small external iliacs, you have to put a 24 French sheath up. We'll put a 10 Viabond in there and like expand it, basically rupture the iliac. But usually we'll wait like 4 weeks, 4 to 6 weeks. Because you don't, similar to your TAVR patients, you don't want to have someone with a big aneurysm hanging around for many months.
One quick question, actually great presentation. Why not, once you did the balloon and you stretch the vessel, why not do the TAVR right there and then finish it with stents, so then you don't have to wait? I don't know if that makes sense. But.
Yeah. Good question.
Yeah, go ahead.
And I guess the concern was performing TAVR at the same time was contrast load, and the big thing was also stent dislodgement. But as you said, at least we have to wait 4 weeks. And then the contrast eyes, the patient optimization, all these were taken into account before we can perform like another procedure on the patient.
It's only 10 cc's of contrast. Go on. It's not that much. So, but yeah, I understand it. The other thing I was thinking, like, is there any other way to get this valve in? And if you remember, the very first TAVR was actually transeptal. So that's the only other consideration is a transeptal integrate approach.
No, it's a great case. I just want to reiterate Dr. Berlakis' point that these stents, even though after 2-3 months you think that they are endothelialized, given the tightness of the sheet around the stent, I think probably the safest way to do it, if it's possible, is to do it before you put the stent. Balloon it, put your sheet, because while your sheet is in there, you're occlusive. And finish the procedure, and then after that, you can finish the case with, whatever endovascular intervention you need to finish with.
And if you really were fussy about the contrast, you can do these without contrast too. Just throw a TE probe down, and you can do it that way as well.
Yeah, I agree. At our institution, we oftentimes collaborate in really tough TAVR cases between the endovascular team and the structural team to at least create a pathway for our structural guys to deploy the TAVR or whatnot. Congratulations on a great case.
Thanks.
Thank you.
Thank you so much.
Congratulations.
And last but not least, we will invite Dr. Zancanaro to the stage to discuss valve in tendon, first case of tendon outer frame degeneration. Thank you.
Yeah, good morning, everyone. I'm Edoardo Zancanaro from San Raffaele Hospital in Italy. I know what you're thinking as surgeons here, but I promise that I will not bite you, any of you. So today it's a pleasure for me to show you the first in-human case of sapien dyne, as we call it, because it's a case of tendine degeneration that treated with sapien. So I have nothing to disclose. So start with the case presentation. We have 63 female with dyspnea and peripheral edema, but the juicy part is that history. So first of all, the patient underwent a type A dissection, and we treated with Bentel and cabbage. But 4 years later, we end up with an Evita procedure, so means that we replace all the arch. And some years later, again, we have the emergency TEVAR for problem with endoleaks of the prosthesis. Nevertheless, thoracoabdominal aneurysmectomy for problem with the prosthesis as well. But at the end, we succeed in 2019 to implant the tendine. What else do we have to know about this really complex case? Actually, the STS was quite high, 6.7%, and also Aeroscore 2 was 7.5%. So we perform a TOE, and what we have seen is a tendine degeneration, but a particular type of one, because there is no leaks, perivalvular leaks, or no problem in the leaflet itself, but more outer frame degeneration. This is kind of, as you can also see from the picture, the stable picture. So this is some numbers for you. Reduced left ventricle ejection fraction, and also reduced right systolic function with pulmonary hypertension. So this is the CT that we perform in order to have a preoperative planning, in order to see also if the valve was normal position and so forth. So the clinical challenge. Well, actually, this was the first case for us of this kind of degeneration. The patient was not surgically feasible. and actually there was no paravalvular leak to close. So the idea was to take a Sapien 3 Ultra, because we know that Sapien 3 Ultra has a higher frame, covered stent, and to cover with PTFE strut in order to have a customized valve all over covered, and crimp in the delivery system and deliver the valve. Seems easy, not that easy. This was the idea, to be distal. What does it mean? It means that the problem was from, as you can see from the green line there, we need to cover and to close these two passages. In order to do that, we had to, of course, have our customized valve to close and to be a little bit more ventricular than a normal implant in case of valve in mitral. Okay, so this was the procedure. We crossed the tendine with an Agilis catheter, and we decided to put 2 Safari wires for this reason, in order to have a body balloon ready to help the valve to pass through the septostomy that we have done, because it's transseptal, of course, procedure, and then, of course, the other one for the valve. We use actually the balloon technique in order to help the Sapien to pass through the septostomy, but not for the implantation. Let's see if anyone, like someone of you, can see what happened during the implant. Yeah. So we can say, Houston, we have a problem, or maybe Austin, we have a problem, but we had a atrialization of the valve, not embolization, just atrialization. So was not in the position that we wanted. In fact, we still have a moderate regurgitation. We tried to post-dilate, but was completely useless. So the idea was to have another valve. We customized another valve, and we implanted another valve, another Sapien. This time, with the same technique, with the same strategy, in the right position. This is the result: good hemodynamics, good echo result, and good, of course, angio, since you can see there. So this is the pre, this is the post, with an acceptable gradient of 3 millimeters of mercury. So the follow-up was fine. Patient is alive at 6 months, no hospitalization, and a stable gradient. So what we have learned, valve in tendine is feasible. Preoperative planning is the key to success. We can say distally is the line of treatment for this kind of patient, and multidisciplinary team and our team discussion is essential. I would leave you with just my final tip. Be prepared to have another Sapien ready on your table. Thank you very much.
Thank you. Great case. Paul?
No, sure. Okay. Edoardo, fantastic presentation. So I don't know if people can really appreciate some of the aspects of what he did, but you know, the tendine has been criticized as something that is not really good for valve-in-valve because of a double frame design. And the reason being is that if you the double frame simply will not allow you to match the outer frame, because the double frame has the double frame. And so for you to use that as a ceiling segment and position it correctly was very smart. I was actually, I don't want to say I'm a genius or anything, nothing like that. I'm really humble, but I could see where your Sapien was, and I was really concerned that the narrowing of the outflow was going to cause that atrialization. So it's a very important learning point and a very important point to share as a teachable moment. So I thought it was a great case, and congratulations. So.
Thank you.
It was great. I have no idea what you were showing, but that was great.
Okay. Good. Nice. So I guess no questions.
Any more questions from the structural heart people over there? Because I look at this and saw beautiful colored pictures, but it's like me in a TAVR.
But we have an Evita procedure, but I am not able to speak about it.
All right, great job. Thank you so much.
Thanks.
Thank you.
If you give us a minute, we're going to score everything, and we will announce the winners. 2 minutes.
All right, so we will go ahead and announce our 3 final winners, one for each track, actually. So without further ado, for the coronary track, Dr. Thuy Pham for her case in distorted osteocoronary stent masquerading as type A aortic dissection. Come on up and get your certificate. Dr. Pham, get your certificate. Would there be a photo opportunity as well? All right. Thank you, Dr. Pham.
I just want to say that it's not a millennial thing. We don't give out participation awards, but all of you participating was fantastic. So it was not as easy as it looks in terms of deciding the winners. So thank you all.
Actually, I want to say we did have more than 100 record submissions, more than 100 submissions. It was extremely hard. Even making the finals was tough, and even tougher now. So thank you all for submitting the cases, and look forward to having even more next year and expand the session.
Yes, I actually personally love hearing the peripheral cases. Actually, I love hearing all the cases. So thank you, everyone, for submitting your cases. So our next winner is for the peripheral is Dr. Rafey Feroze.
Good job, Rafey. All right.
And just to remind people, actually the winners do get $1,000, and then they get a prize, and then also get invited as faculty for next year. So congratulations again.
And last but not least, Dr. Edoardo Zancanaro for the structural track. Thank you, everyone, for sticking it to the end. And obviously, thank you for the directors for this wonderful session. We'll see you next year in Denver.